Dear Jorge, thank you very much for inviting me to your extremely interesting RE meeting. And I will be talking today about the RayOne EMV IOL. I have no conflict of interest. This is a well-proven design we all know, but the optic design is different. It has an aspheric anterior surface, central optic that induces spherical aberration that gradually towards the periphery get less for a better contrast vision in mesopic conditions. It's a non-diffractive design for less halo and glare, and the EDoF effect is around about 1.5 diopters. If we look in the variety of IOLs classification chart, I would place the IOL here in between monofocal and EDoF, but a little bit more, to my opinion, on the EDoF side. I'll tell you later why. You can implant this IOL very easily. This is my first implantation through a 2.0 millimeter optic. Today I implant it only with irrigation without viscoelastic. Works perfectly fine. What I especially like about this IOL design is that you can turn the toric version in both directions. And once you're over the target axis, you don't have to turn it again 360 degrees, but you can turn it 5 or 10 degrees back easily. So that makes surgery very easy. If we look at our patients for cataract surgery, they are of course very different and they have their individual needs. And if you ask the patients, most of them don't want to wear glasses after surgery anymore. So how achieving spectacle independence, a life nearly without glasses with this IOL? Going back in history, we started with our blended vision concept on EDoF IOL, and that we then called the Düsseldorf formula, because the classic monovision, of course, is not a good idea if you have in a dominant eye target refraction of emmetropia and a non-dominant eye -3. That's simply too much. So you have a blurry vision. You have to use an optical trick that you implant EDoF IOLs in the dominant eye emmetropia and the non-dominant eye -1.5, so that with the EDO effect of those IOLs you have a zone with spherical aberrations that the patients can better deal with it. And it's not exactly this study about the Düsseldorf formula, but those are data from Dan Reinstein and Press Beyond. The concept is not so far away, I would say, and we started 13 years ago, and have done now over 8,000 cases and had only three treatments to emmetropia needed. So the blended vision with EDoF IOL really works, and I'm so convinced of it. I had Presby EDoF Smart Surf Trans PRK to my own eyes. That's why I don't need glasses. Here you can see the defocus curve of the RayOne EMV, and here you can see another graph that explains the blended vision. And the nice thing is you can individually grade it to the patient's needs. Those are our first experiences with the RayOne EMV, and these are real-world data, blended vision without correction, and you can see that there is quite a big defocus capacity if you test the binocular vision. So when we ask our patients, what can you do without glasses? 42 of them, the first 42 said, we can do sports, drive a car, work, PC, laptop, and even read a book in good light conditions. But none of our patients could read small print. That's a big difference to trifocal IOL. We didn't have any complications, and the good thing was nobody was reporting about halo and glare. And if we gave the patients this halo and glare chart, they pointed at one of the two top pictures and never the lower pictures, as it can happen with trifocal IOL. And as we all know, patients don't like halo and glare, can easily turn into a white shark for us if they can't drive a car anymore. How do we implant the RayOne EMV toric? With Lensa, femtosecond laser marks on the capsulorhexis, because then we always have excellent cyclotorsion control. On the other hand, and I think this is important to point out, as we promise our patients life without glasses or nearly without glasses, I think we have to be cataract refractive surgeons. Why is it? Because if you promise life without glasses, you have to be able to do touch-up surgery. If you do a smile, or if you do excimer laser surgery or implant a Rayner sulcus supplementary IOL, that doesn't matter, but at least you should be able to do it, because if you're not, you inevitably produce unhappy patients. So I hope I could convince you that with the RayOne blended vision, the Düsseldorf formula, you are able to treat your patients individually. Thank you very much for your kind attention.